All right, welcome everyone to our session today. I'm going to go ahead and share my screen so I can get the right going. So today, as a venture out of the out of our fellowship committee, I thought it would be good after now being 3 months into our new program requirements to kind of talk about them and make sure no one's having any issues. So we have some very special guests joining us today. I'll introduce those in a moment. And then we'll overview the ACGME process to revise these program requirements. We talked a little bit about this kind of over the past couple of years, but I just wanted to frame everyone for those maybe who hadn't heard that process, just to make sure everyone's on the same page. Discuss some key program requirement revisions, kind of picked out the ones that may be most stressing to program directors, faculty, and then have that open discussion with the program directors and core faculty, getting questions answered or kind of brainstorming as a group, even to kind of think about what we are looking at. All right, our speakers tonight include Dr. Bert Fields. He's the founder and emeritus director of the Cone Health Sports Medicine Fellowship in Greensboro, North Carolina. He's a professor in the Department of Family Medicine at the University of North Carolina, Chapel Hill. He's past president and charter fellow of the AMSSM. He currently serves as a member of the ACGME Family Medicine Review Committee, and he was a member of the writing group that did the recent revisions to the sports medicine program requirements. Thank you, Dr. Fields, for joining us. Next up is Dr. Mark Stovak. He's joining us on the virtual dais today. He is the current president of the AMSSM. He was a founding program director of the Sports Medicine Fellowship at the University of Kansas School of Medicine, Wichita Family Medicine Residency Program via Christie Health. He currently serves as faculty in the Sports Medicine Fellowship at the University of Nevada, Reno School of Medicine. He was also a member of the writing group that did these revisions. Thank you, Dr. Greenberg, for allowing Mark to join us, and that way he can get to where he needs to get to. And then last but not least, our third speaker is Dr. Irfan Asif. He's the Associate Dean for Primary Care and Rural Health Professor and Chair of the Department of Family Medicine and Community Medicine at the University of Alabama, Birmingham. He has extensive experience as a Sports Medicine Fellowship Director and faculty. He was lead author, along with Dr. Stovak, for a consensus statement, kind of developing standards of excellence for our Sports Medicine Fellowship training programs. It was published in BJSM. He's currently a chairperson for the Collaborative Research Network and was a member of the writing committee for this revision. Thank you all three for joining us today. I'm going to push a button to show this picture. All right. We'll go through a quick overview of the process. I don't know if Dr. Fields, you want to go over this, but the new revision process kind of starts with a writing group, and the members of that writing group are here. And they take significant stakeholder engagement. And with that, I think this is where I'll turn it over to Mark, because I think he can, and Irf can go through our next slide, which is, we are the stakeholders, AMSSM. What did we do to help develop these new program requirements?
Yeah, I can go through this slide. So this is kind of the process that has gone on over the last 7 years prior to writing these new requirements. So we started out a long time ago with the scope of practice document for AMSSM, and that's been updated. We also did a sports medicine branding task force through the board. And some of the things that came out of this branding task force were that we ended up dropping the primary care from primary care sports medicine. So we're just keeping it as sports medicine physicians. And it also showed that one of the reasons that people were especially interested in referring patients to sports medicine physicians was because of their expertise. And so we really looked at, what could be done to increase the expertise that was gained by our fellows during the fellowship year. And that led to this document that Irf can talk about, and the Fellowship Performance Index. And it also ended up leading to the Tracy Ray's task force on training of future sports medicine physicians, and how, again, to increase our expertise in sports medicine. So I'll let, someone's drawn on the slide there, but I'll let Irf take over for this requirements of excellence document.
Yeah, I think, so Mark and I have previously been co-chairs for the fellowship committee within AMSSM, and a large part of our interest is really trying to train sports medicine physicians with the highest bar and the highest quality. In order to do that, we tried to write a document that didn't have any teeth, really was just a bar that people could aspire to, and that was called the Fellowship Standards of Excellence. And so we put that document out several years ago, and the idea was, hey, not everybody might be able to do this, but here are some things you could do to improve your fellowship program. We then went through something and created what's called the Fellowship Performance Index, where anonymously people could submit information about what their fellows are doing in practice related to procedures, different rotations, what they do on the sideline, training room, and could submit that information, and then we could share that with everyone, again, in an anonymous fashion, so that people could see what others are doing and get an idea of if there were areas to improve within the fellowship. And ultimately that led to some of the work that Mark's going to talk about related to continued stakeholder engagement. And I think one of the things that's important for the ACGME document is that, again, we spent several years trying to do this, and you can only make revisions once every 10 years with the ACGME. So that's why we started this process early, but it's taken us actually 7 years to get to this point. And so I'll turn it over to Mark to continue to build on this.
Yeah, the other authors on that document were Dr. Tracy Ray and Dr. Amanda Weiss-Kelly for the Program Requirements of Excellence document. And then, as we looked at this and we're thinking of how we could raise the bar, we did this, Tracy led this task force for the future training of sports medicine physicians. And that kind of led to the question of length of training for fellowship. Is 1 year better? Is 2 year better? Is forming our own specialty better? Outside of residency training. And that eventually led to 10 town hall meetings, broken up by areas of the country and led by various people. There was a moderator for each of those, as well as a board member, and then or a task force member. And then that we used the data from the town halls and the responses that we got to the questions from that to come up with some surveys. And those surveys were done specifically for program directors, for recent program graduates, and then for prospective sports medicine fellows. And then these results of these surveys were all shared with the ACGME, and really were incorporated into the rewriting of the requirements based upon the feedback that we got, mainly from the program directors, but also with the input of the other folks that were graduates and future fellows. So after 7 years, that's the point that we got to actually write the document. And that's where Dr. Fields can probably come in and explain how that process occurred through the ACGME.
So the ACGME, as you said, makes major program revisions about every 10 years. And this was a timely period because we were doing the revision for family medicine, which are still the majority of the sports medicine programs come out of family medicine sponsorship. So the timing was good. And the way the ACGME works is for the review committee, there are about 10 of us in family medicine around the country who serve as the review committee, and one of us will take a special sort of interest in the family medicine fellowships in certain areas, and I'm assigned sports medicine in that. I'm the one sports medicine physician on the review committee. In order to do this revision, we had seen all the input from the various surveys and various input that AMSSM did a fabulous job on putting together, not only from program directors. Over 100 program directors made considerable input into the discussion of what changes should come about, but younger physicians and prospective sports medicine physicians. So we'd seen all of that, but in addition to that, we'd seen input from all the stakeholders, which includes the specialties that sponsor sports medicine fellows. So it could be pediatrics or internal medicine or family medicine, et cetera. So we had input from that. We also had input from the ACGM as a whole on their various committees will look over the program requirements and say, are these too complicated? Are they too extensive? Are they not extensive enough, et cetera? So there's a lot of input goes into the process. I was then asked to make contact with the AMSSM and pick 2 leaders who had a particular interest in program development. And the names I was given, actually, Mark was recommended by the ACGME as a leader who they had communicated with at prior times. And so Mark and Irf's names both were featured prominently and nominated by Tracy Ray and others as people who would be good to work on this revision with me. So then it fell up to the 3 of us to take in the input from all the various sources to look at it, look at the current program requirements, and start the process of writing revisions. As we would write the revisions, these would go back to the staff at ACGME to help us refine those so they could be in the format that they're supposed to be for program requirements. And that was the general process. We took quite a bit of time, several months, in working on these, revising them, getting them right. And I think that hopefully we got the input that fellowship directors in particular wanted to see in the program requirements. So I'll turn it back to Rick.
All right, so the next set of slides are the ones that Dr. Fields has that kind of go through some of those major kind of key revisions. I can get to that. So, there we go. All right.
So we wanted to make a fairly short summary of what we thought were some of the key provisions in the new program requirements. And this I presented at AMSSM in April. But the take-home points were that the new sports medicine ACGME program requirements, they were reviewed by program directors, AMSSM members, the public, and all programs sponsoring sports medicine fellowships. So we tried to get wide input of the program requirements in the development process. Interestingly enough, the consensus particularly from program directors, is that without making major changes in the program revisions, the changes we would make would improve education in sports medicine fellowships. So there were a lot of core requirements that were not going to change. There were a lot of things that were going to stay the same. There were a lot of things people were already happy with, and those we tried to leave alone. One of the most interesting aspects of this was the independent practice provision. And this was really one of the things pushed hardest by those providing input, is that why would fellows who already may have their board certification completed not be able to practice in their own specialty for a portion of the program that's required, rather than being supervised in their continuing primary role? So, and we felt this would really help some of the programs, particularly some of the programs who were in rural areas who were struggling to finance their program, if the fellow could actually generate some income from the time they spend in their primary care discipline. It might help offset the cost of fellowships. The revisions, we tried to really encourage wellness and some aspects of exercise as medicine, but we didn't find that we had enough of the consensus or input to place some strict measurable requirements. A measurable requirement is one that a program would get a citation for. And so we didn't feel like, while we wanted to push the wellness and the exercise medicine, we didn't want there to be measurable outcomes, or we couldn't figure out which measurable outcomes would allow us to make this in a way that it would lead to citations. So you'll see emphasis on this in the document without strict program requirements that would lead to a citation. Next slide, please. So the independent practice requirement. This allows the sports medicine fellow to spend up to 20% of their time in the independent practice in their primary specialty without supervision. It seemed inappropriate that we could graduate these people from residency, they could go into independent practice, but when they went into fellowship, they were no longer allowed to do independent practice. So if it's built into the curriculum, this time that's spent, then the financial support could either, however your program arranges it, but it could financially support the overall cost of the fellowship. This replaces the supervised program requirement for time in the primary specialty. So you don't have to have both. It's not that you have to have supervised time in the curriculum and independent time. You just have to show you're spending 10 to 20% of your time in your primary specialty. It actually received the strongest endorsement of any change we made if you look at the program director surveys. And the one thing that we put in that I think is a significant change, there were programs that perhaps were having people spend 40% of their time in their primary specialty. And we felt that was excessive and would take away from sports medicine education. So we put in that this cannot exceed 20% of curricular time. Next slide. So scholarship. If you look at citations that are handed out to programs around the country, what are ones that the ACGME hands out most commonly? And one of those is scholarship. And program directors must demonstrate annual scholarship in listed categories. And the listed categories are right in the program requirements. They include things like, are you participating in any grants? Are you publishing any book chapters? Are you publishing a peer-reviewed paper? Are you presenting at a major forum that's either local, regional, national, et cetera? Actually, we took out the local as being enough for the program director, but then your core faculty also should demonstrate some annual scholarship. So that the idea behind this is we're trying to make an educational learning environment so that, particularly with nearer fellowships coming up in smaller places, they needed links to have support for scholarship so the fellows would have the same scholarly experience that is occurring at any location in the country. AMSSM has gone a long ways toward assisting with this because of the national broadcasts of various lectures and ultrasound training, et cetera, that has been really helpful to many programs. So fellows continue to have a requirement that they must show some scholarly activity. That was not a change. That was already in the program. And we felt that if fellows had to have this requirement, why would we not expect this for a program director or core faculty? Next slide. So protected time for key sports medicine staff. Program directors must have a minimum of 20% non-clinical time for program supervision. We'd actually lobbied for more than that, and most of the program directors wanted more time for this, but the ACGME program requirements are always a delicate negotiating battle between institutions and what we as academicians may see would be ideal for curriculums. And so the compromise in that is that they required a minimum of 20% non-clinical time for program supervision. Core faculty must have a minimum of 10% of time for program supervision. And then program coordinators must have a minimum of 20% of time for program support. So all of these are minimums. This does not say you cannot have substantially more than that, and most programs actually do. One reason we couldn't expand them further, because I think the ACGME feels that even though in sports medicine, the consensus of our group was that we wanted more required time, this would put us out of line with what happens in other fellowships in all the other disciplines with the ACGME. And they will not allow fellowships to go above these minimums in any of these other sorts of fellowships that exist. Next slide. So the program curriculum, we said it had to have certain components, and there are quite a few components that are not mentioned here, but some key ones are that look to see if the programs offer a broad curriculum beyond just musculoskeletal diagnosis and injury. Does the program incorporate something about wellness and exercise? Are we getting this into the program so that it's a key part of curriculum? What about chronic medical conditions that affect sport and exercise? Not just the high school or college athlete, but those adults who might have chronic medical conditions and are participating in recreational sports or even competitive sports. But this should include some sports cardiology. Neurology is a key topic, particularly with concussions being the #1 thing listed as a needed medical training on the surveys we saw, and as well as some of the other subspecialties, endocrine, et cetera. Interpretation of key diagnostic tests. Do you know what to do with a pulmonary function test? Do you know what to do with the nerve conduction velocity, et cetera? Knowledge, but not necessarily experience with orthobiologics. We didn't feel we could push orthobiologics any harder than we did in the curriculum without pretty strong evidence-based medicine saying that this was a key part of our education. But we felt that every fellow should know what's going on in this field. Is it going to become a major part of our practice or not? And are we going to develop the evidence necessary to push it further into our curriculum? Competence in musculoskeletal radiology. Everyone felt that fellows should be comfortable learning to read their own films, learning to look at their own MRIs, learning to look at key sorts of radiologic tests that their patients might have. And then finally, some practice management related to independent sports medicine practice. If we're training these people to go out into practice, have we given them some preparation to understand what it's like to be in a private practice, what it's like perhaps to be in other settings, and did we prepare them well for that? Next slide, please. In terms of clinical care, we felt that every fellow should have broad experience in the diagnosis and treatment of musculoskeletal injury. That's a continuation of previous requirements. But there's more of an emphasis on the current requirements on POCUS. Ultrasound is becoming a key part of sports medicine, as all of you know. It's becoming increasingly used all throughout the country. And so we felt that fellows should know how to do good diagnostic ultrasound of all major joints and an EFAST examination. Also included in the program requirements are using ultrasound for diagnostic or for therapeutic injections, et cetera, using ultrasound guidance to help make these more accurate. One thing that was left out of old requirements that we added to these was we think all fellows should have some experience with casting, splinting, and bracing, and we spelled that out so that it was part of the specific curriculum. Fellows must have access and be able to obtain consultations to staff members in disciplines throughout the sports medicine for the variety of sports medicine problems that may occur. This was important to the ACGME that we don't establish fellowships in places where fellows can't get the adequate backup to assess a sports cardiology problem, to assess a special neurologic injury that might happen to a sports medicine patient. So all of these were key parts of the clinical care continuum in sports medicine fellowship. Next slide. So finally, I'm not going to discuss the AIR program tonight. That's not the purpose of this one, but just to make you aware that for those of you who have an interest, Dr. Newton is still very interested in any programs who might wish to pursue the AIR program.
All right. Again, thank you, Dr. Fields, for that overview of those key things. In response to the various questions that we had gotten kind of over the past 6 months, when we got word that these were coming down, I had put together kind of a general kind of overview that I can go through of the program requirements. So they're broken down into 6 kind of categories. Oversight, personnel, fellowship, fellow appointments, educational program, evaluation, and then the learning and work environment. For 3 of those sections, there was really no changes. For part 5 and part 6, there weren't any changes. They added some of the exercises medicine wording into the number into the first kind of category of things. So it leaves kind of 3 categories that they did make some changes to. Personnel, that was some of the bigger ones, and this is one where Dr. Fields kind of had talked about this already. Part of this then leads into, what information do you need in your web ads and things like that. And so kind of putting those in there is that you have to have your program director, at least one other board certified sports medicine faculty, and then one orthopedic surgeon. Really, that's the extent of who needs to be on your kind of web ads, faculty roster there. You could put more people in if they help your program, especially maybe to get extra scholarly activity, and the like, but they're there to show who's supervising your fellows on a daily basis. Again, Dr. Fields really talked about the protected time, and then really one core faculty member needs to be identified for every 2 fellows. So for some of the larger fellowships, which there's not many, so they may need more than 2 kind of core faculty, more than 1 core faculty. And then there's some other things where the fellows have to interact with certified athletic trainers. I would think that's most programs. There are some places where certified athletic trainers are hard to find, and so it's making sure you're doing there. And then you have to have access to all of these specialists, but there's not requirements like that they have to be listed in your faculty roster anymore. Fellow appointments, we had actually a couple questions on this one that came through over the course of the year. It is now allowed that you can take osteopathic neuromuscular medicine residency graduates as applicants to the sports medicine fellowships. I've seen a couple kind of roll through in the application process. It is an ACGME accredited residency. And so they are now allowed to be selected as fellows. And then the educational program, that's where there was a lot of changes in what we should include and not include. And then this also included that scholarly activity. And so I just kind of put that here because there were some questions, concerns about that kind of stuff. So they want more things there. I see some chatter about the independent practice. We can get to that in our discussion here. That 1 or 2 half days has to still count in their 80-hour work limit. So some of the programs maybe who are ER based that have maybe some longer hour continuity experiences, that could come into play there. And again, some of the fellow scholarly activity, it can be like a case-based, a research-based, or even a QI project, but it needs to really be presented somewhere for it to really count. So that's that part of the portion. So I wanted to have the bulk of the time we have to be more of a interactive experience where we can ask our esteemed guests here questions that the ACGME might have, that have the answers for, or people who have experience in managing programs to kind of weigh in. It's not the official line, but we can kind of help each other educate each other the best. So I'm gonna like stop the sharing real quick. That way we can see each other. I have been told we are allowed to, if you want to unmute yourself, if you're able to put your camera on so we can see you, you can. Otherwise, you can just speak if anyone has any questions. And then we can kind of address that question about the independent practice. So looks like we might have a taker.
Hey guys, Chris Miles here at Wake Forest. Thank you very much for this. This is super helpful. As you were discussing the personnel, you mentioned 1 board certified sports medicine provider and 1 board certified orthopedic provider. Does that orthopedic provider have to be part of the core faculty? And if so, can you describe how that funding would work because my family medicine department probably does not want to fund 10% of an orthopedics salary to have them as core faculty.
The requirement is that you have a board certified orthopedic person as a part of your faculty, not your core faculty. You're going to find the same trouble in most programs. Is it's also, how do we push them to do the scholarly activity if we're not paying them? So the reality is they need to be part of your faculty, Chris, but not necessarily part of your core faculty.
Rich Lord thanks you for that answer.
I have a related question. So at UNM, all faculty have like at least 20% of protected time. And some departments will say, oh, your sports medicine, like your protected time, we expect, some of that to be teaching. And since you're sports medicine, we expect that to be, teaching the fellows. Does that count as the 10%? Or does it have to be in addition to the designated time that all faculty have for teaching and education stuff?
Rachel, designated time for working with fellows. And it means the time that you're not generating revenue independently. So I think, if you're the program director, some of that time would definitely have to be administrative. Perhaps if you're the associate program director, it has to be administrative. But if you've got other faculty who are core faculty and their time with the fellows is primarily teaching, that should be just fine.
So as long as so it's a faculty member has 20% protected, and that's, 10% of that is their teaching time, that's acceptable, even if it's not written in their contract specifically.
Yes. I mean, if you got a survey from the ACGME, you document how those faculty that you have used their time. That's what we're going to review. Where we've run into, I review virtually all the sports medicine programs except the ones in North Carolina that apply or are being reviewed. And we rarely will ever put a citation down if you demonstrate what your faculty are doing in teaching with a program. We're not nitpicking exactly what it is. It's only if you're trying to claim that you're seeing patients and supervising the fellow at the same time, et cetera.
Yeah, and just a little bit, I did ask Eileen Anthony, who's our executive director, about how these citations would come about. And it's really what we as program directors kind of provide to the ACGME, either in the web in our annual update or in some of the surveys. So if the fellows notice, gosh, there's not a lot of time where I'm able to be taught, and the faculty are just seeing patients and I'm not really learning, they're gonna see that in the evaluations on that resident survey, or I'm sorry, on that fellow survey. Same thing with the faculty survey. So that's really the data they're using to start that review process. You're not going to have to fill out timesheets and send things in. It's really based on kind of the gist of what they're picking up in in the data they have available to them. Hopefully that helps kind of clear that up a little bit. They're not going to be asking for your timesheets and something.
That's correct.
Hey guys. So my question is, I put this in the chat too, just, a general question in terms of all these changes, how is ACGME going to enforce all this stuff?
Well, Elliot, what you look at is that, what Rick was just saying, each year there's a fellow survey, each year there's a faculty survey, and we look very carefully at that data. When you're up for reaccreditation or when you're up for initial accreditation, there's a site visit. That site visit goes through every single one of the program requirements. Some are the core program requirements, which every residency basically has to abide by. And then the specialty specific program requirements for sports medicine, they would be looking at those. If your site visit report came back and said you're not teaching, and I've seen this recently, the fellows were not getting any teaching at all of diagnostic ultrasound, for example, that would show up as a citation when you saw it again. If your fellows had no experience providing injections to the common joints, that would show up as a program citation.
All right. There was a question from Kendra that I think was interesting. I saw it on the family medicine side, but I didn't see it specifically in ours. The question was, can you split the 10% core between two different faculty? And so if you had a program that only needed two, that you only needed two people, can each do 5% instead of 10%. I know in family medicine, you can divvy up all of that amongst people. It said it kind of and buried it. I saw that somewhere. So
I don't think that was the intent of the program requirements. We were saying the minimum for a core faculty member should be 10%.
all right.
Rick, there was one, I think, above that too from Dunworth.
Yes, I was going to get to that one. I think I see Ian turned his camera on, so if he's ready to go.
Yeah, sorry. More, Bert, I know you had mentioned that for the exercise medicine, you guys had looked into potentially making some of those more solid and measurable. Is there anything off the top of your head that you remember that had been thrown out there as ideas that for those of us that have kind of more exercises medicine embedded may want to consider putting more in?
That's a challenging question, and to say, what should you document to show that you're doing this? I think that probably where most of this is going to come out will be in both site visits and in surveys. Do you feel like you're being taught to write an adult exercise prescription? Do you feel like you're being taught to provide exercise for patients with chronic disease, et cetera? So that the whole concepts, as we mentioned in curriculum, need to not just be straightforward injuries, straightforward evaluation of common orthopedic injuries, but those injuries that might occur in special populations would be part of what I think is exercise medicine. Those exercise prescriptions you write to help people deal with more effectively chronic disease, and those exercise prescriptions we write just for wellness. So I think that's the surveys. I think ultimately, if we make the program requirements stronger for exercise medicine, I think they'll come down to things like trying to assess, does the fellow know how to do these certain skills? Irf could probably add more to that too, yes.
Yeah, no, thank you. I think a couple things for Ian and Bert maybe that we could chew on. I think one thing was just trying to make sure that the education in this space is up to speed for everybody. And as part of the Exercise Medicine and Physical Activity Promotion Summit last year, we put together some work. And that work, one of the things that's a deliverable is a document that describes what it is that you could do at the med student, resident, and fellow level. So I would encourage people to look at the document to see that outlines pretty clearly some of the things that you could do. Again, there are no teeth to this document, but it gives you some examples of things that you could incorporate into your fellowship. Some of those things include gaining medical knowledge. So just like Bert said, how to write an exercise prescription, and clearly that's a deficiency within fellowships. We published some information both from fellowship directors and from fellows, and we asked the fellows, for example, how many of you were taught how to write an exercise prescription? And 2/3 of them said that they were not taught how to do so within their fellowship training. So in order to help people, because the standards can vary from fellowship to fellowship, we've put together exercise modules on various topics, and in total, there are going to be 8 modules. 7 of those are done. So if you go to the AMSSM website, You'll see in the banner the exercise modules, or exercise medicine and physical activity promotion modules. We're finishing the last one with Martin Schwalmus from South Africa, so there'll be 8 total, and any of you can use those. They're freely available to incorporate within your fellowship. So there's the medical knowledge piece, and then just as Bert was outlining, there's the how do I put this into practice? So writing exercise prescriptions, learning how to write strength and conditioning programs, learning how to get out into the community. There are lots of things that you could do, and both the document that I described as well as the modules will be a good source of information for you, and I encourage you all to try to use those.
And that's perfectly the type of information that if you provided in a survey, that you'd gone through those type of modules, that you'd be meeting what the ACGME expects to show that you're putting that as part of your curriculum.
Hey, Rick, I'm just watching this chat and I'm not sure we can keep up with it, but a lot of the questions that are coming through are really questions that probably either only Bert can answer or Bert may have to get help to answer, because when we wrote these requirements, Eileen and the ACGME still had to develop how they were going to make the reporting sites match the requirements. And so a lot of these questions are asking about reporting and all that stuff for core faculty. So I think either Bert's going to have to answer those or we're going to have to get help on those.
Yeah, I was going to summarize when you develop your roster, faculty roster on web ads, it generates, you can pick who's core and who's not core. The questions stem around who has to complete who do we need to fill in the scholarly activity for? Is it all people listed there or just the core faculty? Because in the program requirements, it makes it sound like just the core faculty need to do that. Now, you can always have other people, and if they do things, you can add their scholarly activity in. But it's because there might be, I'm just trying to think, because you might have to put someone who is a site director because it's an off-site that's not necessarily a core faculty. So will we have to do faculty scholarly activity for them, and will they get the surveys? And I think that's where 2 of these questions are stemming from.
Yeah, I could comment because I look at this all the time. We're really going to look at it, if we're thinking of giving a program a citation, we're really going to look at core faculty. But the requirement states that you're trying to make a scholarly environment for the fellow. So any scholarship you show, whether it's among your orthopedists like Heather asked in one of her questions, or if it's in any of the people that you consider as your general faculty, that shows more evidence that your fellows are working in a scholarly environment. So I would encourage programs to list the scholarship they have, and particularly some people, the best scholars in the group that really stimulate the fellows are not core faculty. But the requirement specifically is we're trying to be sure that the type of people we're choosing for program directors and for core faculty are scholarly. And so that's where the citations would come from if they did not have that.
All right. Ted, he has a question that kind of ties into this is, if you have multiple sites, you list the site director because you have to in your roster, but then they don't necessarily have to be core faculty. I couldn't get an answer from Eileen the last time I asked her is if they were going to streamline the process for our faculty filling out the faculty survey. Like, we're non-core faculty members going to be getting the survey. And I don't know if there's an answer to that yet. But if only 2 people, if only 2 people are filling it out, or 1, because you have a smaller program, can you get that data yearly, right? We can't get it on our fellows yearly because there's only 2, there's not the 4 threshold. So you'll be getting aggregate data then most likely. And I don't know how that will work to help you make program changes, so.
I understand your point. If you only had 2 faculty, you would have to aggregate a few years to see if you had the type of data to make some decisions with.
Yeah, I think that's why everyone listed on that roster, even if they're not core, probably needs to fill out the faculty survey part of it so that you can get some information from everybody. Okay.
And hopefully you'll get participation. So, but you must get the participation from your core faculty.
All right. Any other people who want to take a shot at a live question while I look through the rest of I think we covered most of the ones that I see in the chat there. They
Can I make one comment, Rick?
Absolutely.
There seems to be a mistaken notion that sometimes that the ACGME has any role in how you either fund your faculty, fund your fellows, et cetera. And they don't. They just basically write requirements. Our understanding, and I think there's a lot of misconception about this, is every institution can do their budget differently. But when we get pass-through funds for residents, we get them for the primary residents, but your fellows are not funded by CMS unless your institution is shifting monies that are provided for other primary residents into the fellowship funding itself. So that's why it's not necessarily double dipping if you go ahead and let them have an independent practice provision. And so, you know, this is one of the most common questions we get, and you're not in violation of CMS rules unless you in your institution are designating that we're shifting funds from CMS, which were not provided for sports medicine fellows, to cover their expenses. Irf, you made some comment about that, and I don't know if your institution is doing it differently, but we've vetted this in several places and with lots of legal sources.
Yeah, no, everything that you said, I think just distinguishing the ACGME from CMS is really important. And then if people are getting funding from a different source, then, you know, that doesn't play a role in the CMS funding if you're not getting CMS funding. So yeah, appreciate that.
But again, and realize CMS, when they come in and they look at each fellow you have and how much Medicare provisions they provide, they're not giving you credit, unless I'm totally mistaken. They're not giving you credit for your sports medicine fellows in terms of CMS funding to your institution. Your institution can take that pool of money and decide to shift it to support your fellowship, but CMS is not paying you for the fellows like they do for a family medicine resident, a pediatric resident, an internal medicine resident.
All right. Anyone else there? I was looking at, we covered some of the other topics that we had questions on. And again, one of the things is some of the fellowships are set up in a block rotation, right? And so maybe a core faculty member may only, you know, get them not on a continuous longitudinal fashion. How, you know, still needs to get to that. Is it 10% of the time when they're with them, or 10% of the entire year?
No, the reality is it can be averaged over the year. So if you teach the fellows 3 months, but during that 3 months time, you have 40% of your time, you're over the 10% requirement with that, et cetera. So it can be averaged over the year. It doesn't have to be every week you're doing 10%.
And then that includes times like journal clubs and teach any non-clinical teaching. Okay.
Correct.
Just because, which is sometimes a lot. So.
And you know, that's why a lot of programs are meeting this requirement of core faculty. A lot of core faculty are running things like the journal club, different conference schedules. They're involved in that on a routine basis. And that's academic, that's teaching. That's what we're wanting that protected time to be for.
All right. All right. Again, some more questions just regarding that independent practice, and I agree kind of with Irf's. It was his taking off the emergency break from ACGME being that sticking point of not allowing it. But again, ultimately, it's how your program's funded, what your hospital system can work out, and then going to there. There was a question. It was more of like a comment of, as you know, I mean, we're starting interview season, right? Has anyone heard from applicants? I'm not sure if they're quite there yet, of saying, how is your fellowship funded? Am I allowed to get extra, am I allowed to potentially get extra money? Now, some of that money might go back towards to fund the fellowship, not directly towards, an extra salary stipend, if you will, to those fellows, depends on how the fellowship's funded, but I did see that kind of comment there. I don't know if anyone, we only had 1 week of it. I don't know if there's anything that you'd have to comment on, Bert or Mark.
I mean,
Taking
from my
credit.
side, yeah, if I had to wear my chair hat, I don't think I would necessarily look for the fellows to get additional stipends from this. I think there are other things that, at least at our institution, for trying to make sure that salaries across the board are, fair, so that, fairly similar across the groups. You can certainly do moonlighting and other things, but I think where I would actually take some of this funding on our side is to think about how do you fund some of the personnel to do some of the scholarly activity that Bert's talking about. We oftentimes need help like statistical support, IRB, other things, and we don't have a means to be able to pay those. So first thing is to be able to budget neutral, to pay your salaries, your benefits, conference attendance, other things from an educational perspective, or faculty time to support the fellowship, your coordinator time. But in addition, are there other things that you can do? And scholarly activity is probably something that could be helpful at programs to enhance, and for us as a discipline to be able to do.
I don't think that I don't think the intent of that rule was to make this the NIL of the ACGME fellowship programs. I think this was really meant to, really even save the primary programs money and not having to schedule another preceptor to cover the ratio if you go over 4-to-1 for the fellow. I think there were lots of intents, but it was definitely not to increase the competitiveness of recruiting residents by paying them more for moonlighting.
That's correct. And particularly if that is a part of the curriculum, then the program can decide how they structure their payment system, but that needs to be curricular time. Moonlighting is separate, as Irf mentioned, and moonlighting, as long as you're staying within your hours and so forth, is still allowed.
All right, we do have a couple new questions here. All right, has there been any talk of increasing the number of ultrasound injections within the ACGME requirements? There is, this person's coming from a place where maybe more advanced practice providers are doing these injections after just taking weekend courses and stuff like that. I don't know.
Hey, I can talk. I can talk. My videos, it's not letting me come on. But yeah, there's been some interest from APPs, and it would help. Oh, there we go. Sorry, I just got off my bike. Okay, so it would help me to help in talking to like the powers that be, like the chair for orthopedic surgery, some of the higher admins, why this is not really appropriate. I would have it just would help me have more kind of, well, hey, this is what the fellow has to do. They have to do this number in fellowship. It would just help me give more kind of some sort of background behind my power to stand up against some of the powers that be. Since APPs are so much cheaper than us to hire, there's been a push for this recently that they can, and I just don't find that appropriate, that you can do a weekend course and learn everything, shoulder, ankles, and like literally this is what they want to do. And so I just wanted, if I had some more power to stand on, that would be more, it'd be helpful to go against in some of these meetings with the higher ups at our hospital.
Yeah, it's an interesting sort of question, because I think all of us would like to see some standards that were generally applied. On the other hand, the ACGME doesn't apply standards of competency. We figure every institution will have medical committees that are going to determine, are you competent to do a cardiac catheterization? Are you competent to do an injection, for example? And how you list that, what we look at, if in your program you say we determine competence to do a shoulder examination by having done 5 observed shoulder, we want to know, are you documenting that? Are you following it? So we're looking to see if you have a rational approach to determine clinical skills, but we can't actually put out what competency should be because it varies so much from place to place. That's how that's determined.
So I was involved way back when on getting ultrasound into our requirements.
Yep.
And there was lots and lots and lots of pushback from the standpoint that the ACGME did not want to have any procedures listed separately in requirements, making one procedure more important than another procedure. And we were eventually able to get the ultrasound in there, but I don't ever see them. And I mean, Bert lives it every day, but I just don't see them from any of my conversations ever putting a number on anything.
No, we would be citing so many programs if we did. And, you know, even in our program director survey, Mark, you'll remember this, 24% of the program directors objected to us putting ultrasound in as a requirement. So it wasn't a small percentage. And that's because in a lot of places, they don't have faculty who can actually teach it.
Hopefully that sort of answered Carrie's. It kind of really comes not really from the ACGME, but that's probably more a local decision that, you know, sharing expertise and trying to maybe work with the credentialing committees to say, well, let me see your 50 shoulder and, you know, whatever that is. We have one from Jason Deck to clarify, a single fellow program cannot count the program director as the one core faculty member. Is correct? Is that a correct statement?
I would have to check that particularly if they were a new program. You know, because I know we say we have to have a core faculty member for every 2 fellows, but could you have 1 fellow and 1 program director? I think that's still legit. Mark, do you know?
I don't know. That sounds like an FAQ to me.
Yeah, I think we'll double check that and get back to you just to be sure. But the way it's written is that, you know, if you have to have a core faculty for every 2 fellows. So if you had 1 fellow, can your program director be adequate? I think it has been that way in the past, I'll be honest.
The question that was just put in there was already discussed, so maybe you should reiterate that.
Yeah, it goes back to independent practice time, that 10 to 20%. Is that weekly? Can it be averaged over the year, month?
You can, yeah, the point being of the time that you spend in your primary care discipline, the way you schedule that, you just have to be able to document they're getting the adequate amount of time.
And the same goes for core faculty time. You know, just doesn't matter how you use those 200 hours as long as you use those 200 hours.
Right. We're trying to be flexible. I mean, you know, one thing that I'm trained to review these programs, and they encourage us to be flexible and try to determine our programs really fitting in all the things that are needed in the curriculum, not how you do it so much, but are you able to fit it in a way that the fellows later on surveys are going to say, yeah, I got a good education. I got exposure to all of these things.
All right. Any other questions from our program directors, our core faculty?
You sent us, sorry, Jody.
Hey, one comment about the question about a 1 fellow program and the program director being core faculty. I mean, you have to have a second person to be accredited. So why couldn't you use your assistant program director, your second person as your core faculty, and then it kind of takes care of the issue? I don't think there's a question there, right?
You're certainly accredited with that. The question I was wondering is if, you know, because a number of new programs are starting, can you start a program with just a fellowship director and a board certified orthopedist if you have 1 fellow? And I need to clarify that, to be honest.
I think the difference comes in that if you list the second person who's required as a core faculty member, you have to give them 10% time. And in my system, they're trying to figure out ways to not have anybody listed as a core faculty member except me, so they don't have to pay anybody for billable time, basically. Now I have 3 fellows, so I have to have a second core faculty member. And now the big question is exactly when do these go into effect, so we can keep it just being you that we pay for protected time as long as possible until we're possibly going to get a citation.
But I thought the second person, the assistant program director, had to spend at least 10% of their time with the fellows anyway. So, I mean, how are they going to meet that requirement if they're not faculty teaching the fellows or however? I mean, they can't be assistant program director and spend 5% or 0% of time with the fellows, because it's in the ACGME requirements where it was before anyways.
But in the past, that second person wasn't funded. Jim, I would think that these went into effect already, so they're already in effect.
Well, that's what I've been saying. That's what I've been telling them, Mark, and I'm just running into.
They are in effect. But to be honest, we're not going to do citations on the new program requirements until they've been in effect 1 year.
I'm not going to tell them that, Bert, because I'm trying to get them to give me somebody with a protected time.
I understand the strategy, and I agree with you, Jim, totally. But so, you know, when I'm reviewing now, I'm basically reviewing programs based on the old requirements until next July.
Thank you.
There won't be a citation. Will it show up as an area of concern? Some programs, some GME departments put those two almost on the same level. They shouldn't be, but
yeah. Well, I mean, what we would be writing, honestly, if I'm looking at a program right now, we would be saying the new program requirements will require you to have this in place.
Okay, that's fair. And then I do want to bring up, so in the program requirements, I think that, so there's always this question about the APD. So there's in the world of ACGME for sports medicine fellowships, the APD doesn't exist as a defined role. Is that correct? Okay. It's always kind of been there. And that's something the program can decide. If you want to name someone your APD, it doesn't mean anything through the ACG. They probably will be a core faculty, most likely, but there isn't that APD for sports medicine. Family medicine, other specialties, those exist for those specialties, and depending on how many fellows will depend on how many residents will depend on how many you need, but it doesn't exist as a thing. I actually looked back through 18 years I've been, I cannot find those words in any of those past ones, because I've saved them as they've come along, and I don't find those words in any of the program requirements that I've seen. So
you're correct. You don't have to designate an APD. Yeah. That's your choice, but you do have to designate someone as core faculty.
Correct. All right.
Hey, Rick, you asked a question on our preparatory email.
Yeah.
About does the program director and the core faculty need to be in the same department? Maybe you can talk about that, because that's confusing.
Yeah, so there was quite a few programs that are split, their faculty split between 2 different departments. So say family medicine, orthopedics, family medicine, PNR, whatever the specialties are. The question seems to boil down to who's 10%. The 10%, because there could be a very different salary amongst, of time someone would need to pay. I know that's not in the realm of the ACGME, but can you comment on that particularly? Like, how would you address that as a?
Well, I think core faculty could be in multiple departments, honestly. Mm-hmm. That's not an issue. It's, do they have 10% of their time to teach the fellows? That's protected to do that, or to administer the fellows. But you do have to have, if you've got extra fellows, you do have to have a second person certified in sports medicine. So that gets down to, if you had a sports medicine certified person in pediatrics and family medicine, that would be fine. But if you had family medicine and orthopedics, that might not be fine.
Yeah, I think it comes to be like you have someone who's sports medicine trained from our fellowships, but they get employed by ortho department as opposed to the family medicine department where the fellowship's housed.
And that is fine.
Yeah. So you can cross, it's just a matter of like their 10%, that's where it's going to come down to.
And we don't look who provides the funding or what department it is. We look to see, do the faculty have the qualifications required to be the core faculty that you have?
All right. I think we've covered all of the questions that were in the chat.
Rick, there was, I think I was going to say the air pilot was something that we kind of briefly talked about. In the family medicine world, the air pilot is definitely getting some legs. There are programs that are vying to apply for those spots in a pilot phase. And so just to recap about the AIR program, the idea here is that you might be able to take a residency training program, like a family medicine program with 3 years, and add a year to make a 4-year experience, and to use things like elective time towards enhanced training beyond just that 1 year. So when you think about all the things that you might do within a sports medicine fellowship within 1 year, if you have 6 months of elective time, for example, plus the 12 months, you might be able to create an 18-month experience. Within the family medicine space, some of the areas that we're prioritizing for doing the AIR pilot include leadership training, rural training, and also research. And I just wanted to highlight that so that you knew some of these may not be your traditional fellowships that you think about, but things that might help the discipline as a whole. And so if you think about this from a sports medicine perspective, it might be neat to see if programs are interested in this. Obviously, you need to be able to talk to the parent program that you're a part of to see whether or not you would want to pursue this, but they're looking for 100 programs or so to pilot the AIR program with the idea of doing multiple different fellowships. Again, that wouldn't all be sports medicine, but doing that with these additional tracks. And so it might be neat to think about that if folks are interested from a sports medicine side, and I'd be certainly happy to help. I know other people, Bert, Mark, others may also be interested in sort of trying to help our discipline if that's something that we'd like to do.
Yeah, and it is, unfortunately, so far, it's only sponsored by family medicine, but you literally could have 4 years of continuity in your residency where you had sports medicine in each of those 4 years of residency, with your last year being heavy in sports medicine. And if you look at the new program requirements, I was on the writing group for the new program requirements in family medicine. We've eliminated a lot of requirements in the family medicine requirements. So you're not talking about 6 months of elective. You might be able to work related, what I would call selective rotations that really fit well with sports medicine, to be 12 to 15 months more than you would normally get in a fellowship. So it's a very attractive program. I don't think we'll get funding for 100, or when said that, but I know that Warren is really trying to pin down the funding to get quite a few programs started to test the process.
So interestingly, some of the things that you could do with the pilot in terms of the funding is to apply in such a way to where, you might be able to bill in that 4th year with some of your time to be able to pay for that additional year. So that would be something that, we could say, well, we're interested in doing this pilot, but in order to do that, we need to have X in the 4th year happen from a billing standpoint. When I talked to Warren about that, he was certainly supportive. Again, he's not the one that makes the decision there, but that's something he would certainly support as we go to the ACGME. And then the other thing is our program is funded from a residency standpoint using teaching health center dollars. So that's oftentimes used to support those with rural training or FQHC support. Turns out that the teaching health center dollars actually will support a 4th year. You just have to apply for it. So our program has 20 residents, and we're actually thinking of applying for 20 additional spots to do these air pilots, again, in a variety of things. We have a lot of things like rural programming, OB, emergency medicine, addiction, to where we might try that out. Again, I don't know how it's going to go, but that actually is a way to get around some of the funding issues that you described, which a lot of people have those concerns.
And CMS, so far, we've actually talked with CMS. They've been favorably inclined toward this, particularly if it was in a FQHC like you were talking about.
I did have a question, and I didn't get a response back from Warren, is with, if you're taking someone into that, right? Obviously they're deciding that. How does that work when they get to their, like, how does it take like NRMP and matching, and because you're actually like selecting someone potentially, or they're applying, do they still have to apply for a fellowship? Like, that's where it gets a little sticky, and like I couldn't rationalize how that works at the back end.
The NRMP has said they would like a separate number for that.
Okay.
And it's called a revision number. So if you took someone in that and they decided not to come, then that spot could revert to your regular residency complement. But what I've been talking to Warren about, and some others have expressed the same, let's say you took someone who matched in a 4-year air program that was going to do sports medicine, and after a year they decide they really want to do OB. How do you handle that? Do you have a 1-year opt-in, opt-out for the program or the candidate? And so some of those details have not been fleshed out yet.
Yeah, I think to add to that, I think that you would have to apply for this. So it's not something we could do just this second, like say, oh, we're going to leave this call and start doing it. I think the application process is something that they're actively thinking about, and Jay Feder at the ABFM is the one that's sort of working with Warren Newton on it. Once they get a few programs to apply to it, what they said they were going to do was to provide that as for other people to be able to use to apply. And I think the questions that you brought up, Rick, about separate application number and those sorts of things, I think that'd be, hopefully those questions would be addressed.
It sounded like it would be at least a couple of years off before you would even like take in people into those programs, is what
so we're actually applying for it now with I'd say that they actually are saying that the first people might be available to take them in 2023, which again is accelerated, but it's a possibility. Mark, I saw you had your hand up.
Yeah, I was just going to say that's going to be a challenge for the AMSSM Fellowship Committee Chair, because the Fellowship Committee Chair gets the honor of tracking down every program that didn't use the match for their full complement, and seeing if they went outside the match yeah, you get to do that, right, Jason?
No, it's Casey's job. I'm moving off in April.
That was the worst job of being the fellowship chair. But so that's going to be another problem for them to track down. Hey, I just want to clarify something, and Bert, tell me if I'm right. When I'm reading this requirement, it says that you must have a program director, you must have a second person, and you must have an orthopedic surgeon, and then you must fund the core faculty member, excluding the program leadership, which is a really common ACGME term. So you cannot, in my interpretation, count the program director. Like you have to have 3 people, including the orthopedic surgeon, when I'm reading this.
Yeah, and I think that's right, Mark. But what I'm wondering is if because someone put in here they were thinking of starting a new program. I'm not sure if you have to have that second person in place the first year of a new program. That should be part of your plan, but I would have to verify that, because I know we've had some leniency about not only fellowships but residency that way. If it's a new residency, how many core faculty do they have to have if they only have 6 residents because they just have the first year of their residency? So that's an ACGME sort of decision. I'll try to clarify that.
Hey, Rick, can I ask one quick question?
Sure.
And this is something I put in the questions that we all talk about privately. It's been brought up a few times. is I was wondering if Bert or anyone else can comment on the fellowships. This is primarily in the larger fellowships that are multidisciplinary, where it's housed in one particular department, but it's fellows that have different spots. So you may have EM and FM, FM, PM&R, whatever the case may be. But and while it's not the ACGME's purview where the 10% come from, obviously that could fracture the core faculty, because now you're asking one particular department to account for fellows that are with different backgrounds and how they've been traditionally run. So I wonder if that's going to be a concern starting in the 23-24 year.
I'm not sure that I can answer that fully, Jason. I know that, you know, the program director has the ultimate responsibility for who is designated core faculty, and certifying that all fellows that go through the program would get an equivalent education. So I would say that if you got, and this came into play a little bit with one of the programs that was guaranteeing an ED and a family medicine person, because the ED was requiring so much extra time in the primary care practice of ED. They basically were funding them by doing a lot of shifts. So that's where that requirement we put in, that you can't be doing more than 20% of your time in your primary discipline.
Well, I was just looking at actually not from the fellows side, but from the faculty side, the core faculty, not the PD.
And are you talking about the core faculty? Then I'm not sure I understood the
Basically,
question.
there's fellowships that have been operating for many years that are in faculty or in multiple departments, but the fellowship is housed in one department.
Right.
So all those faculty, I mean, let's be honest, you know, the institutions are not going to just willingly give up 10% from other departments. So those faculty aren't going to be core faculty anymore, and that's going to change the fellowship potentially from an educational standpoint starting a year from now.
That's true. And again, like I say, the ACGME puts the requirements, but we don't tell you how you have to work out that you could have core faculty in more than one department. But it's allowed, but we're not telling you how to fund it.
Yeah. There was a circle back question to the AIR program from Christine Marsh about whether they need a fellowship. So this would, as far as I understand it, this is like a ABFM funded program. So after if your program does this, it's approved, you're in the cohort, that resident who finishes those 4 years would be eligible to take family medicine boards and sports medicine, CAQ. That's how I was understanding it.
That's correct.
Yeah. So it's not, they would have to do this 4th year. It would be like, embedded fellowship, essentially.
Yes, you have to show that you met all the requirements that any normal fellow would have, but it may not be all in 1 year. It may be spread through the 4 years.
Yeah.
Yeah, and I think, Rick, it's not funded by the ABFM. Right. So Bert's point earlier about the funding having to come from the program and how are they going to do that? Those are definitely real questions, but people are trying to address those.
Yeah, it's sponsored. Let's say sponsored, so they'd be allowed to take the boards as if they were, but they could be medicine team leader and during their fellowship, because you specified that's how you made the program. So you can get a little bit more flexibility with your personnel. So perfect. All right, and then just as we're closing here, I wanted to make sure we had some resources. There's something called the Program Director's Guide to the Common Program Requirements. It's on the ACGME website. I think it's invaluable that you go through there because it really breaks it down. There's also a few videos on the website. It's avoiding common errors in your annual update that you have to do for web ads. I think those two things are should be must watches. The staff at the ACGME, especially in our RRC, is super helpful. And then one last question, Mark. I know other specialties have that video of like the update of the update of the program requirements for each specialty. I know there was a you were working on it, was being maybe produced for sports medicine. I don't know if that ever got any traction or not.
Repeat that. I'm not quite sure, Shane. We did a video for the milestone update.
Yeah. So there was one for family medicine that Stacy Potts, I think she was the writing lead, did for family medicine, kind of explaining everything. I don't know. I mean, this is kind of what this served as, but I didn't know if there was something in the works for sports medicine.
I don't think we've done that, Mark.
Okay.
No, I did a video for the milestones,
Yeah.
or an audio, I guess I should say. But I haven't heard anything being requested for this.
That's what the purpose of this was, is to have the people who wrote be available to answer questions and hopefully get the answers that were needed.
Rick, I do have one more question, if you don't mind. You mentioned the
Sure.
new residency program that can apply for fellowships, the osteopathic neuromuscular medicine program.
Right.
And I did receive some emails from some people who've gone through that program asking, do we entertain applications from people from that? I didn't know how to answer, because for the half day to full day continuity in their primary specialty, I don't know where to put them. I don't know what would qualify, because honestly, I don't understand what that residency is yet. It's the first time I had heard of it. Can you just give me some ideas to how we would do that as part of a program that's basically, my program is primarily family medicine, internal medicine, and emergency medicine. We occasionally take a pediatrician. We don't have the infrastructure right now for a PM&R candidate, but I don't even know where I would put a person with this new program. Can you help me with that a little bit?
Well,
Anyone?
Bert could probably speak for the ACGME. I can't speak for the ACGME, but I would think you would have to have a specialist with that background in your community to put them with for 10% of their time.
And it's been most attractive to big DO institutions who train residents in that and would possibly have faculty could assist with that. But like I say, I looked through their curriculum. They have a robust curriculum, and they would probably be well qualified to do what we're asking them to do. But it's not a specialty that I had ever encountered before.
Yeah, I had the email. I basically had the same answer, was that I don't know enough, and I will, get back to someone, like obviously for this year it's not going to work, but potentially in the future it could figure out what to do for them, if they matched.
Thank you.
All right, I think I appreciate everyone's questions, and definitely appreciate our speakers, Dr. Stovak, Dr. Fields, and Dr. Asif, for their valuable insight. We recorded this, so we should be able to have this if those who didn't get to watch it, and hopefully we'll have a follow-up during the fellowship forum in Phoenix. All right, have a good night, everybody.
Have a good night.
Bye.